So this online lecture will represent Chapter 7 in your textbook entitled Airway. I think as a first responder, I've taught you the steps of opening the airway and assessing the airway, but after you do that, you also need to realize that there will be devices that you will have to use to assist you in your artificial ventilations for your patient. Specifically, we're talking about the bag valve mask, we're talking about the resuscitation mask, but in addition to that, you might have to also utilize supplemental oxygen, or you might be forced to administer oxygen to your patient. And oxygen could truly be a life-saving drug. It has already been said, and is worth saying again, if you do anything for your patient, the airway care that you provide, opening it and maintaining an airway and ensuring adequate breathing is probably one of the most important things that you as a first responder will ever do. And so to segue into that, we'll start talking about different airway management techniques. So if you will recall, I said that the number one cause for an airway obstruction was the tongue, right? And so one of the biggest things when a patient is unconscious is that the tongue becomes relaxed and it falls into the posterior portion of the throat, specifically into the pharynx, right? And so we have two different components to the pharynx. We have the nasal pharynx and we have the oral pharynx. And so I think it's important that you also realize that we have airway tools that were designed to open the airway by going through either the nasal pharyngeal airway or the oral pharyngeal airway. And we can see these devices to the right here. The top three devices would represent nasal airways, and then the bottom two devices would represent our oral airways. These devices, when inserted into an unconscious patient, truly help to remove the tongue from the back of the throat and help to increase the efficiency in which we are able to artificially ventilate our patient, because we no longer have the tongue blocking the back portion of the patient's throat. And so next on this list when we're thinking about airways is that, first of all, we realize that the airways in this particular picture are curved. The reason they are curved is because they are contoured to fit either the top of the mouth and the top of the nasal cavity, right? And so they should just slide in and fit in and be perfect. And so today what you'll learn is how to measure the airway so that we make sure that we have an airway that is capable of protecting our patient from injury, but also capable of removing the tongue from the back of the throat. These airways are designed to extend down to the larynx, right? The larynx becomes the conduit through which air moves from the trachea to the larynx and into the alveolar sacs. So these airways play a crucial role in removing the tongue from the back of the airway, or another way said, decreasing an airway obstruction and allowing us to artificially ventilate without any obstruction. The first airway that we're going to talk about is the oral airway. The big deal with the oral airway is to make sure that the victim is unconscious. Anyone want to tell me why? Well, the big reason is because of the gag reflex. Remember that if we put something in the back of our throat, like let's say our finger, what tends to happen? We tend to feel like we're going to vomit. That is the gag reflex. So we do not want to elicit the gag reflex in a conscious patient. So we never ever insert an oral airway into a patient who is conscious. This is strictly for an unconscious victim. We'll talk about fitting on the next slide, but it's very important that we fit and that we have the appropriate oral airway. If not, what we could do is induce vomiting even in our unconscious patients. So what we're going to basically do is we're going to grasp the lower jaw and tongue, and we're going to open up that airway. And so when we look at this next slide, we can kind of see the fitting of the oral airway. So when we fit an oral airway, if I were to number the slide, what I would do is number it and tell you how to fit it exactly. So step 1 would be to measure the oral airway. To measure the oral airway and to determine the perfect fit, what we have to do is we have to measure from the corner of the mouth to the mandibular angle. And we'll do this in lab of the mandible. And then after we've measured and we have the appropriate oral airway, the next step would be to insert the airway. And when we insert the airway, we always start with the rounded portion pointing up towards the roof of the mouth. It is when we meet resistance, so part 3, when we meet resistance with the back of the throat, that we then rotate the oral airway so that this portion is pointing down and the airway sits in our patient's mouth like such. So airway fitted. So again, we have to measure from the tip of the mouth to the mandibular angle to get the appropriate airway. And in such a case, someone said, well, would you rather have it too short or too long? The best answer is probably too long. If an oral airway specifically, is too short, then it tends to push the tongue back into the posterior aspect of the throat and actually creates more of an obstructed airway. So you'd rather have it too long, where it's moving the tongue away from the back of the throat, than too short, where it's pushing it back into the back of the throat and causing an obstructed airway. So with a child, insertion of an oral airway is a little bit different. Remember, in the adult, what we said was that the airway had to be pointed this way first, and then once we hit resistance, we would rotate it and it would sit down this way during the final insertion point. Well, you will notice that with a child, that is a little bit different. That in fact, we start with the airway in the position that it's going to rest. So with the airway up in this position, typically what we would want to use is some form of tongue depressor to hold the jaw and the tongue down, and then we would just nicely or slowly insert that airway into the child's airway to remove the tongue from the back of the throat. It's a very simple technique. You might meet some resistance from the mandible and the maxilla, so you might have to actually pry open the jaw if the victim is truly unconscious and has been unconscious for several minutes. But other than that, it should be a smooth insertion. So moving to the nasal airways, which are very painful because, as you can imagine, inserting anything that isn't your finger into the nasal airway can be painful. The big deal with the nasal airway, and what's interesting is that with the nasal airway, you can actually insert these in conscious victims, right? So it can be conscious, and it can also be unconscious victims as well. Whereas with the oral, it's strictly used for unconscious victims only. So for our nasal airways, it can be conscious or unconscious. And I think that's nice because it allows for some versatility in its use. Some of the big rules of thumb with a nasal airway is that it must be lubricated, so lube it up with some type of Vaseline or some type of oily substance so that it slides in a little bit easier. And then the big deal is that you want minor resistance. You don't want a whole bunch of major resistance. If so, pull the airway out. Something must be obstructing the nasal cavity. And then last but not least, and I think this is a big one, is that we never want to insert a nasal airway on someone with a head injury. You could increase the bleed or make the head injury worse, and we don't want to do either of those. So how do we fit a nasal airway? The measurement for the nasal airway goes from the tip of the nose, so the most outer portion of the nose, to the tip or the most bottom portion of the earlobe, and you can kind of see that here in this picture. So first thing we're going to do is measure the airway. Again, it goes from the tip of the nose to the distal portion of the airway. Number 2, you want to lube the nasal airway, and then last but not least, we want to insert it. And what you don't see here is that there's a beveled portion to this airway, or a part of the airway that actually has like a little bit of a hole. And so we want to insert the airway with this side, the beveled portion, going towards the inner septum or towards the inner nose. And again, we need to measure to make sure that it's just perfect. In head injured victims, we do not want to insert a nasal airway, and the key to success with insertion of a nasal airway truly is the lubing of, because then it just slides right into the nasal cavity. So I've talked a little bit about patients vomiting in the midst of artificial ventilation or in the midst of treatment, and they're unconscious and what to do. One of the things I said is you can put them in the recovery position, and that works well. Sweep your finger through, clean the mouth out, and then you keep going with your artificial ventilations. However, there is another technique that you can use that does not involve you using your hands, and that is suctioning. And so suctioning really is this idea that you're using some sort of device to basically remove foreign material from the mouth or nose of your victim. This device can be manual or it can be mechanical, and we'll kind of talk about the differences between the two on the next slide. I think last but not least, how does suctioning work? Basically, it creates this negative pressure system which allows for materials to be removed from the patient's mouth. So how do we use a suctioning device? Because they seem like they're pretty straightforward, but again, they're not as straightforward as you might suspect. I think the first thing that we need to do is we need to turn the victim's head to one side. And as you could imagine, just like in the recovery position, this is done to kind of create a gravity dependent position, a position that would encourage fluids to kind of be removed from the victim's mouth. Obviously you want to open the victim's mouth to get the suctioning tip into the patient's mouth. And then one thing that you want to do before you start suctioning is you want to sweep away any large debris. Think about vacuuming. When you vacuum something that's large, it kind of clogs the vacuum. Well, the same thing happens or occurs with suctioning. If there's large chunks of food or particles in your patient's mouth, it would just get in the way of the suctioning device. One thing that we want to do is we want to measure the insertion tip. The same rule applies just like it would for an oral airway. We want to go from the corner of the mouth to the edge of the mandibular angle. And the reason we do that is because we don't want the suctioning tip to be too long such that it presses on the posterior aspect of the throat, specifically the pharynx, and causes the patient to vomit. We're going to insert that suction into the back of the patient's throat, and then as a rule of thumb, we are going to suction. Now, what research is showing and what's been reported is that we really shouldn't be suctioning for any longer than the times listed here below in this table. There are several different reasons why, and we'll discuss them in detail right now. One of the major reasons that you don't want to suction for longer than the times listed below is the fact that when we are suctioning, what we are also doing at the same time is that we're removing air and oxygen during the suctioning process. And so that can cause a quick drop in the blood oxygen levels and also change the heart rate, right? And so when we have less oxygen within the body, the heart tends to want to work harder to substitute for the lack of oxygen that's receiving to circulate more oxygen throughout the body. And so we have to be careful that as we tend to suction, that we don't suction for longer than the recommended times listed in this table below, so that we don't create an oxygen deficit within our patients. So that brings us to the bulk of Chapter 7, which is really about oxygen administration and or oxygen therapy. When you leave this class, you will become certified as an oxygen administrator, which means you can administer oxygen to patients in need. And so what is required, or what do you need to know in order to determine whether or not a patient actually needs if a patient actually needs supplemental oxygen? Well, it's really about the signs and symptoms that your patient presents with. One of the things that we've already talked about is poor skin color, more specifically a patient who presents with cyanosis. And as you recall, I said that patient would present with bluish looking skin, and if they were of darker complexion, they might be gray and or an ashen color. And so we can see this patient here who has blue nail beds, right? They are cyanotic, and so they might need more oxygen to actually get O2 into the circulatory system to start circulating throughout the rest of the body. There are other signs and symptoms that our patients might present that might also indicate a need for supplemental oxygen, and that might be the person who is unresponsive, right? And so we think about a person who's unconscious, is not breathing, needs some form of supplemental oxygen, whether that comes from the artificial ventilation that we as first responders might deliver, or whether or not that comes from an oxygen tank, is completely up to the resources and the incident manager at the scene of the emergency. Other signs and symptoms would be a patient who has cool, clammy skin and isn't breathing efficiently and adequately, and then obviously the patient who's having difficulty moving air in and out of their body. And then last but not least is a patient who is experiencing blood loss. That cannot be controlled or is uncontrolled. As we tend to lose blood, we also tend to lose we tend to lose oxygen as well, and so that creates an oxygen deficit within the body. So these are the major reasons and or signs and symptoms that would indicate to us as first responders that our patient might need supplemental oxygen. So we talked about oxygen administration. Now we kind of have to talk about the oxygen device, which is an oxygen cylinder. I think it's important for us to know that all oxygen cylinders are manufactured according to strict governmental regulations. According to those regulations, cylinders must be checked at least once in 5 years. And so what that means is if you're a first responder who's certified in oxygen administration and you're working for a facility that has an oxygen tank, it is your sole responsibility to make sure that that oxygen tank has been checked. New cylinders should be checked every 10 years. So if you were to purchase an oxygen tank today, then you wouldn't have to recheck it until 10 years or so. There are different types of oxygen cylinders that are available. Obviously, they vary in both the size and the volume. And even though the volume of oxygen may vary, all cylinders, when full, are at the same pressure, which is about 2,000 psi's. And so we're going to talk about the cylinder sizes because they're identified by the letter. And so the following sizes are used in emergency medical care, and you can see them listed here in the table, going from D through H, with H being your largest cylinder. I think the D cylinders tend to be smaller in nature, and so you tend to see those in your patients who have to use oxygen all the time, that have to actually carry an oxygen on a cart, kind of like your elderly patients that we see with the nasal cannulas, and they're walking around with the oxygen tank. If EMS were to arrive to the scene with an oxygen tank, then more than likely you probably see them with an H cylinder, which is a larger cylinder capable of delivering more oxygen over a longer period of time. Each state, each city, each facility has their choice in which type of oxygen cylinder and which size of oxygen cylinder they're going to carry. Obviously, in terms of price, it starts to increase as we go down and the oxygen cylinders get larger. So obviously, just like any other thing we talk about in this class, oxygen cylinders also have an anatomy to them. You need three things in order for an oxygen cylinder to be an oxygen cylinder. The first thing is an oxygen cylinder itself. It is the actual tall green silver device. You need the pressure regulator, which is responsible for determining how many liters per minute of oxygen we are delivering to our patient. So it is the control device. It controls how much oxygen we give our patient. And then last but not least, we need the delivery device, right? And the delivery device could totally be something as simple as a nasal cannula. It could be the bag valve mask. It could be the resuscitation device. So it's the device that we're going to put on our patient's face in order to deliver oxygen to our patient. As I stated earlier, the volume of the oxygen cylinder is going to vary, obviously, by the size, but the pressure is always constant. It's constant at 2,000 psi's. So we've talked about oxygen administration. We've talked about the oxygen cylinder. Now we have to talk about the oxygen delivery, or the types of oxygen delivery devices that are available to us as first responders. So there are four major oxygen delivery devices that are preferred in the emergency medical care community, and those four are listed in detail here in this table. But one of the first ones that we most commonly see is the nasal cannula, and that's the oxygen delivery device that actually goes directly into the nose and wraps around the ear. We have our resuscitation mask, which we've already talked about, the bag valve mask, and the one that we really haven't talked a whole bunch about is the non-rebreather mask, which is a combination of the resuscitation mask and the bag valve mask. And so when we look at the different columns, the first one we're going to look at is the flow rate, right? And so the flow rate really represents the amount of oxygen that's being delivered per minute. With our nasal cannula, the flow rate is a lot lower because it tends to dry out the nasal membranes, or the mucous membranes within the nasal cavity, and it can actually cause nosebleed. So we want to make sure that when we set our pressure regulator, that our flow is no greater than 1 to 6 liters per minute. With our resuscitation mask, because it does fit around the patient's nose and or mandible, and it has more room for oxygen to fill in its space, you can increase the liters per minute to about 6 to 15 liters per minute. And with the non-rebreather mask, because there is a bag associated with it, the liters per minute can be increased to about 10 to 15. And then last but not least, because we have not only a bag, a valve, and a mask, we can increase the liters per minute on the bag valve mask to at least 15 liters per minute. When looking at the delivery device's ability to deliver a % concentration of oxygen, I think we look at this column here, and it kind of tells the story, right? Obviously, the bag valve mask is probably one of our best delivery devices, along with your non-rebreather mask, to deliver the highest % of oxygen to our patient. So when we have an unconscious patient and we have an oxygen cylinder, truly the go-to devices are the non-rebreather mask and the bag valve mask. The nasal cannula delivers the lowest % of oxygen in terms of concentration. And then last but definitely not least is the resuscitation mask. If you only have one of these devices, whether it be a nasal cannula or resuscitation mask, you're better off using one of these as opposed to breathing artificially into your victim. And so when we look at these numbers here, and then we think about the fact that what we breathe into our patient will only be about 21%. We're still doing better using the delivery devices than we are breathing into our patients, because we still get a higher concentration of oxygen using the delivery devices than we do breathing artificially into our patients. So if you have an oxygen cylinder and you are certified to deliver oxygen to your patient, then the gold standard probably would be either the non-rebreather and the bag valve mask. However, if you're stuck with a nasal cannula and a resuscitation mask, it still beats us artificially breathing into our patients. So when and who can these devices be used on? Well, that's a functional question, right? The two devices that can be used on both conscious and unconscious patients are our resuscitation mask and our bag valve mask. However, the other two devices, the non-rebreather mask requires our patient to be conscious and breathing, because the patients have to breathe in order to get oxygen into the pharynx, the larynx, and into the alveolar sacs. And then the nasal cannula, obviously, because that's going to go into the nasal cavity, and it requires our patient to be have the ability to inhale in order to deliver oxygen to our patient. So again, not only do we have to worry about oxygen concentration percent, but we also have to worry about whether or not the device can be used on a conscious and an unconscious patient. So these are all of the oxygen delivery devices that you might encounter in the field, and these are the delivery devices that you will be certified to utilize if you are using supplemental oxygen. So how do we set up the oxygen cylinder, and how do we deliver oxygen to our patients? This is a checklist of things that we need to do prior to putting on oxygen, supplemental oxygen onto our patient. And so we're going to kind of use pictures to help guide us through these steps, because I'm a visual learner by nature. But if you like the list is here for you to utilize. And so we're going to go into the first slide, which is truly just involves checking the cylinder. So we would say step number one in this scenario would be checking the cylinder, right? So number one, check your cylinder. You want to make sure that it's within that 5 to 10 year check range, that there's a date on your cylinder that shows when the last time it was that it was checked. You want to also confirm, first of all, that it is oxygen, right? Because we don't want to deliver any type of gaseous substance to our patients that is not oxygen. So we want to confirm on the cylinder that, in fact, this is an oxygen cylinder. So step number two, we're going to clear the valve, but most importantly in step number two, what we want to do is confirm that there is an O-ring. It's that little guy right there. The O-ring provides the seal between the pressure regulator, which we'll see in the next slide, and the actual oxygen delivery device itself. So we need to make sure that there is an O-ring, and if there is not, we need to put one on the device right here. So we want to confirm that there is an O-ring. If an O-ring does not exist, we need to go ahead and install one right in this area. The O-ring again provides the seal. So if you imagine turning on an oxygen tank and there's no O-ring, air would go from every which way, but not into the actual delivery device itself. It is a sealing device. So now that the O-ring is in place, the next step would then be to clear. We're going to say clear the oxygen tank. And so what does that mean? It means to turn it on and just let some oxygen flow before we actually attach the actual pressure regulator itself. In step number 4, what we want to do is attach the pressure regulator. So we're going to attach the pressure regulator, and you can see the pressure regulator here. Okay. After step 3 and step number 4, the next step in this process would be to then attach the pressure regulator, as we've said. So tighten the pressure regulator up, make sure that it's off. So we're going to tighten the pressure regulator. And then in our next step, again, we're just continuing to tighten that pressure regulator. And so these are just different angles. Again, tighten the pressure regulator. If you do not tighten the pressure regulator, it will fly off when you turn it on. So you want to make sure there is a good seal between the pressure regulator itself and the actual oxygen cylinder. Once the pressure regulator is on, the next thing that you want to do is you want to make sure that you've attached the delivery device, right? So let's think about that. The delivery device could be the nasal cannula, it could be the bag valve mask, it could be a resuscitation mask, right? Or it could be a non-rebreather mask. So what we want to do is we want to go ahead and attach the delivery device, and then after we've attached the delivery device, our next step in this process would be to turn on the pressure regulator to the desired liters per minute, and then allow air to flow through the delivery device before attaching it to our patients. Air through the delivery device before attaching it to our patients. This is a big deal because we want to confirm that air is flowing before we put it on our patients. Put the delivery device on our patients, and then last but not least, we just want to confirm again that our liters per minute are appropriately set for the particular delivery device. Since this is a non-rebreather mask, we're looking at about 10 to 15 liters per minute. So it looks like we're within normative values here. So one technique that you may be asked to perform in an emergency situation is Cilix maneuver. Cilix maneuver has two purposes really. The first one is that it's going to compress the esophagus so that it is less likely that vomiting is going to occur. Then it also helps make the trachea more visible to the advanced provider, so the EMT or the paramedic who's attempting to put in some type of intubation, right? So some type of tubing into the throat to actually open up the airway a little bit more. When requested to do so by an advanced provider, perform Cilix maneuver as follows. So your patient's going to be in a supine position, or they're going to be on their back. And as you can tell in the picture below, they're going to be on their back, and they're probably going to be unconscious if we're performing this maneuver. You're going to basically use your index finger and your thumb of one hand to provide a downward, almost posterior pressure over what is called the cricoid cartilage. It's located right below the thyroid cartilage in the neck. You're going to compress with a steady, gentle force, just enough to compress the flexible esophagus, but not enough to damage the trachea. In other words, to fracture the trachea, right? And you're going to maintain this pressure until either the EMT or the paramedic tells you to stop, which is typically after they've intubated the patient. So what is Cilix maneuver? It's really a maneuver that was designed to help with the process of intubation in patients who are unconscious. It helps make the trachea a lot more visible so that the EMT or the paramedic has an easier transition, an easier pathway to intubate the patients. So this is the